speaker and the chair.
Yes, we can start.
That works for you, Chintan, shall we?
Yes, yes.
All right, thank you. So welcome everybody to another edition of the D.Y. Patil Postgraduate Psychiatry Knowledge Series. We've been doing this for well over 6 years now, consistently every month, and we have been blessed with a good bunch of speakers, teachers, as well as now we have added this entire spectrum of having senior chairpersons as well who can add their own value to the program. So we're happy to host another series today, another talk today by Dr. Amita Shah. She will be speaking with us about the neuropsychiatric aspects of PCOS. It's a very pertinent topic in a clinical sense, as well as an academic and a theoretical sense, because it's something that we deal with on a day-to-day basis. And it's something which definitely troubles all of us, and we would be much the happier for us to learn from what she has to teach us today. And so welcome, Amita, and thank you for accepting our invitation today and sparing your time to educate and illuminate our postgraduate students. We have Dr. Chintan Solanki with us, who is going to chair today's session. Dr. Solanki is an associate professor and the head of Department of Psychiatry at the GMERS Medical College at Gandhinagar. He is the president of the Indian Psychiatric Society Gujarat State Branch in the current year. He has done his MBBS from NHL Municipal Medical College, Ahmedabad, and he pursued his post-graduation in psychiatry from BJMC, Ahmedabad. He has been the winner of the A.V. Shah Award in 2010 at the IPS West Zone Conference. And he has 7 original research papers in various journals to his credit. He is a very humble, a very down-to-earth person, and we are very, very grateful to him to have taken the time out today to be with us and to agree to chair this session. So I shall now hand over the proceedings to Dr. Chintan Solanki and request him to take over. Over to you, Dr. Solanki.
Thank you, Dr. Rasmin. It's really an honor because I am attending psychiatry lecture series probably after most 1.5 years, I guess, because of whatever the schedule, or we can say, I don't have yet PG in my institute, so maybe not that motivated. But really, this is a great chance that I can attend lecture rather than chairperson, being a person who can attend and learn something new. And especially today's topic is very interesting. In our clinical practice, maybe 30 to 40% of the female who has some depressive or anxiety spectrum disorder have at least some kind of PCOS related symptom. May not be PMDD, but at least PMS may be there. And it has been a great honor. Thank you again. And just I would like to introduce now our today's speaker, who is specialized, particularly related in this field. Dr. Amita Shah. She has completed her MBBS in 1997 and DNB Psychiatry in 2002 from JJ Hospital at Mumbai, MD and DNB both. And Amita is a consultant psychiatrist at HN Reliance Foundation Hospital, Mumbai. She has special interest in women and child psychiatric disorder. She is very well read and quite eloquent in her ability to convey complex matters in a lucid manner. So without wasting our time, just I would like to invite Dr. Amita to proceed further and deliver her talk.
Thank you very much, Chairperson, and thank you, organizers, for inviting me today. I will share my screen. Give me a moment. Is my screen visible to everyone?
Yes, it is visible.
Okay. So I will start with 3 case vignettes today. So the first case is of an 18-year-old girl. She visited a gynecologist for irregular menstrual cycles. On examination, she was found to have acne, obesity, and midline hair growth. On investigation, her testosterone levels were high, her fasting and postprandial insulin levels, as well as HOMA-IR, which is the homeostatic assessment of insulin resistance, was high. USG had shown polycystic ovaries. A patient was diagnosed as a case of PCOS. She was started on OC pills. She came for psychiatric consultation with history of depressive and anxiety symptoms of about 1.5 to 2 years duration. Patient was started on antidepressants. At the same time, she was advised to undergo weight loss, dietary changes, and regular exercise. The second case is of a 25-year-old girl. She had visited gynecologist for irregular menstrual cycle. At that time, patient's weight was in obese category. Patient was diagnosed as a case of PCOS and was started on OC pills. She was advised weight loss by the gynecologist, and with regular exercise and dietary changes, she managed to lose quite good amount of weight, and currently her weight has come down to in normal limits. She came for psychiatric consultation with predominant anxiety symptoms. At the time of psychiatric consultation, her weight was in normal limits, but her lipid profile was deranged, and patient was started on antidepressants. And this is the third case of a 28-year-old female. She had visited gynecologist around 8 to 9 years back. At that time, she had visited for irregular menstrual cycles and hirsutism. On investigations, there was raised testosterone levels and polycystic ovaries on USG. She was diagnosed as a case of PCOS and was started on OC pills. But patient could not tolerate OC pills, and she visited many different doctors, even went to naturopathy and Ayurveda and etc. And finally returned back to modern medicine because she could not find any improvement. And this time gynecologist started on metformin, and which has helped to regularize the menstrual cycle. And this patient came for the psychiatric consultation with the history of depressive symptoms of about 2 to 3 years duration, with exacerbation since 6 months before the consultation. And on examination at the time of psychiatric consultation, she was obese, and her investigation showed deranged lipid profile. And patient was started on antidepressant. At the same time, weight loss was also advised. She's undergoing laser therapy for hirsutism. So what is common in all these 3 cases? Just a moment. Yeah. Sorry, it's not allowing me to move to the next slide. Yeah. So what is common in all these 3 cases? As you can see, all of them are young. They all have multisystemic manifestations: reproductive system manifestation, metabolic disorder manifestation, and psychiatric disorder. And psychiatric disorder is one of the common comorbid condition in PCOS. And I'm Dr. Amita Shah, and that is why today I'm going to talk on the neuropsychiatry of PCOS. Now, depression is one of the most common neuropsychiatric disorder associated with PCOS. So my talk today is going to focus on depression mainly. And today, whatever I'm going to talk in next 1 hour or so is just an overview of the literature that is available. Some of the mechanisms which I'm going to discuss today are the topics in itself. And I've tried to include those details and those informations which have more clear as well as more strong association with pathophysiology of PCOS as well as with depression in PCOS. So now we move on. So this is today's agenda. Brief overview of PCOS. And my talk is going to focus mainly on the pathophysiology of PCOS and pathophysiology of depression in PCOS. Today, I'm going to talk in detail about this pathophysiology of PCOS as well as how it links with pathophysiology of depression in PCOS. Treatment of depression in PCOS is essentially same as in non-PCOS group. But there are certain additional points which I'm going to include in this last part of my presentation today. So essentially, we are going to learn the basics of PCOS and basics of depression in PCOS today. So it was first described by Stein and Leventhal. It is a lifelong heterogeneous endocrine disorder affecting about 5 to 15% women during reproductive age group. And as Dr. Chintan said, that many of our patients do have PCOS symptoms when they come to us. And it is a multisystemic manifestation with having endocrine, reproductive, as well as metabolic and psychiatric symptoms. There are different diagnostic criteria available for the PCOS, but Rotterdam criteria for PCOS is most commonly used. As per this diagnostic criteria, any two of the following should be present. So it should be hyperandrogenism, which should be clinical, that is based on signs and symptoms, or biochemical based on investigations. Ovulatory dysfunction, which will be either oligoovulation or anovulation. Polycystic ovarian morphological changes on USG. Now, having only polycystic ovarian changes without hyperandrogenism or ovulatory dysfunction does not qualify for the diagnosis of PCOS, because many women can have polycystic ovaries without having PCOS. There are separate diagnostic criteria available for the adolescent age group. I have not mentioned them in my talk today, but they are available and they can be used to diagnose PCOS in adolescents. The most common clinical presentation of PCOS is menstrual dysfunction, and that is why the gynecologist becomes the first point of contact for these patients. Majority of these patients will have oligomenorrhea with the cycle length of more than 35 days or amenorrhea. Very rarely they'll have polymenorrhea, and some of them will have regular menstrual cycle with hyperandrogenism and ovulatory dysfunction. In adolescent, one can observe absence of established menstrual cycle. PCOS is one of the common causes of infertility in women. The physical characteristics are hirsutism, which will present as the growth of excessive hair growth on the lower part of the face, on the neck, midline hair growth on the chest and abdomen. The hair loss will be more of androgenic hair loss, or what we call male pattern hair loss. Acne will be present in about 1/3 of the patients. Now, in adolescent age group, acne is a very common skin condition that we observe. So having only acne without other symptoms of PCOS will not be sufficient to diagnose as PCOS. Obesity is very commonly associated with PCOS, and acanthosis nigricans, that is dark discoloration of the skin folds and creases of the skin. Metabolic disorder are the most common comorbidity with PCOS. They are also highly predisposed to develop cardiovascular disorder. Depression, as I said before, is the most common psychiatric disorder. Obesity predisposes these women to develop obstructive sleep apnea. And ectopic deposition of fat in the liver leads to non-alcoholic fatty liver disease. So now we move on to the next part of our agenda, and that is pathophysiology of PCOS. And as you can see in this diagram, it shows all different factors during the life cycle of a woman which contributes to the PCOS phenotype. Now, all these factors are not present in a given individual. Some of the factors will be present, and it will be the interaction between these factors which will determine the symptom profile of the PCOS phenotype. Today, I'm going to talk about these 8 pathophysiological mechanisms of PCOS. Now, to keep it simple and for easy to understand, they are being divided into various subgroups, but they don't occur in isolation. All of them are interrelated, and there is complex interaction between each of them, and each one of them can influence or precipitate or aggravate the other. So hyperandrogenism is responsible for the physical as well as the reproductive symptoms that we see in our PCOS patients. And the high androgen production can be of ovarian as well as adrenal origin. In case of ovary, it can be a disruption in the interaction between the intrinsic as well as extrinsic factor. The intrinsic ovarian factors could be like paracrine or endocrine factors, or it could be some genetic variation causing increased secretion or expression of the steroidogenic enzyme in the ovary, which eventually can increase the androgen production. And extrinsic factors could be in the form of increased luteinizing hormone secretion, hyperinsulinemia, obesity, as well as inflammation. I will discuss about these factors in my coming slides. The HPO axis, the hypothalamo-pituitary-ovarian axis dysfunction, is seen in about 50% of women. And this will present as increased LH pulse frequency and pulse amplitude, as well as increased LH to FSH ratio. So I can explain you on this diagram. So you can see this is HPO axis. In normal circumstances, there is a pulsatile release of gonadotropin releasing hormone from the hypothalamus. This causes pulsatile release of luteinizing hormone and follicular stimulating hormone from the pituitary. Now, follicular stimulating hormone stimulates development of maturation of the follicles in ovary. Out of that, one dominant follicle will mature and other follicles will undergo atresia. And then there will be LH surge, and this LH surge will give rise to ovulation. And at the same time, the estrogen and progesterone secreted by the ovary, they will give feedback to the hypothalamus and regulate GnRH secretion. So this is how the HPO axis functions in normal circumstances. But in case of PCOS, there is increased secretion of GnRH for hypothalamus. Now, what does it cause? It increases LH secretion and it suppresses FSH secretion. And that is why there is increased LH to FSH ratio. Now, what is the effect on ovary? There are many follicles which will start maturing in the ovary, but none of them will mature as a dominant follicle. And as a result of that, there is no ovulation, or there is failure of ovulation, causing the ovulatory dysfunction. At the same time, high levels of luteinizing hormone will stimulate androgen production in the theca cells. In fact, increase the androgen production in theca cells of the ovary. And this androgen leads to impairment of the HPO axis. So why does this happen? There are genetic factors which could be responsible for HPO axis dysfunction. Hyperinsulinemia, which I will discuss in my next slide, also stimulates LH secretion. Impairment of negative feedback mediated by the sex steroids, especially the progesterone, is found to be responsible in certain patients of HPO dysfunction. Gaba signaling, this also plays a role. So there are GABA neurons from arcuate nucleus of the hypothalamus. They project onto the GnRH secreting neurons. And GABA acts through GABA A receptor, and it has a stimulatory effect on GnRH neurons. So GABA increases the secretion of GnRH. In case where there is increased signaling of GABA from arcuate nucleus onto the hypothalamus, onto the GnRH neurons in the hypothalamus, that will lead to increase in the secretion of GnRH, which will eventually lead to increase in the LH pulse frequency and can lead to the symptoms of PCOS. And this could be the possible mechanism of PCOS with valproate. Now, about 70% of PCOS women are going to have insulin resistance with compensatory hyperinsulinemia, which is independent of BMI and androgen concentration. In fact, in today's talk, I'm going to emphasize on the role of insulin in the pathophysiology of PCOS, as well as in pathophysiology of the depression. And you will realize by the end of the our talk That's why it is so. And probably insulin plays a central role in the PCOS pathophysiology. Insulin receptors are present all throughout HPO axis, and insulin plays important role in regulation of HPO axis. It stimulates LH secretion, it stimulates production of androgens from the theca cells of the ovary. In case of PCOS, insulin resistance is tissue specific. So liver, muscle, and adipose tissue, they have insulin resistance, because of which these PCOS women are at high risk to develop metabolic disorders. It's the ovary and adrenal glands which are sensitive to the insulin, and because of which the insulin is able to increase androgen production from ovary as well as adrenal glands. Pituitary is also sensitive to insulin, because of which the insulin is able to increase luteinizing hormone secretion from the pituitary. Certain actions of insulin in liver also retain their sensitivity to insulin. So there are certain mechanisms by which the insulin increases androgen secretion from the ovary. One, insulin acts directly through the insulin receptors. Second, it upregulates an enzyme which is called as 70-beta HST, that is 17-beta hydroxysteroid dehydrogenase. This enzyme converts androstenedione into testosterone. So upregulation of this enzyme increases the testosterone levels. Third thing, it stimulates basically the secretion of luteinizing hormone from the pituitary. Now, high levels of luteinizing hormone increases androgen productions from the theca cells of ovary. But here there is a rate limiting step. This luteinizing hormone receptors, they undergo desensitization to the effect of luteinizing hormone. So luteinizing hormone alone is not able to increase substantial quantity of androgen production. But in presence of insulin, this luteinizing hormone receptors are able to undergo what we call as escape from desensitization. So in presence of insulin, the LH or luteinizing hormone is able to increase androgen production in substantial quantity. And last is where insulin suppresses the production of SHBG, that is sex hormone binding globulin from the liver. This insulin action in liver is still sensitive to the insulin, and this leads to increase in the peripheral circulating testosterone. And why there is insulin resistance in PCOS? So there are various mechanisms, as you can see on the slide. It can be genetic, epigenetic, inflammation, varying adaptations to nutrients, obesity. All of them can contribute to insulin resistance as well as hyperinsulinemia in PCOS. The studies have shown that there can be altered beta cell function and insulin sensitivity in this women since childhood. And this then presents as PCOS symptoms in adolescent or early adulthood years. So in this diagram, you can see that insulin resistance, which causes compensatory hyperinsulinemia, which then decreases SHBG production from liver, increases ovarian androgen production, at the same time causes disordered release of LH and FSH from pituitary, and this causes hyperandrogenism and oligo or anovulation, leading to PCOS. Now we move on to the next one. Now, PCOS women are known to have higher incidence of obesity. And this is the visceral fat or visceral adiposity, which is more strongly associated with PCOS rather than the general adiposity. And obesity itself can cause PCOS. So studies have found that in those women who do not have any predisposition or vulnerability, whether genetic or otherwise, to develop PCOS, if they are found to gain weight and become obese, then this obesity can predispose them or can lead to PCOS. Now, why this happens is because obesity itself can induce high insulin resistance and compensatory hyperinsulinemia, as well as inflammation, and this can cause hyperandrogenism. And obesity also suppresses LH secretion, which causes anovulation, and this can contribute to the development of PCOS. Now, all the other mechanisms of the PCOS that I had listed, they all can contribute or precipitate or aggravate obesity in PCOS. So as you can see that chronic activation of HPXs or genetic factors or hyperandrogenism, chronic inflammation, insulin resistance, all of them can contribute to obesity in PCOS. There are two mechanisms which I would like to discuss separately. One is varying adaptations to nutrients and altered energy expenditure. Now, both these mechanisms are the inherent abnormality in the patients with PCOS. So I'll just explain you this with the diagram. So in case of PCOS women, it has been found that they have excessive oxidative stress response in presence of dietary glucose. So whenever they consume glucose or carbohydrate, there will be an oxidative stress response. And this oxidative stress response will then activate mononuclear cells, will activate nuclear factor kappa B, and this will then lead to the secretion of inflammatory cytokines. And this will then cause low-grade inflammation as well as insulin resistance. And this mononuclear cells will activate the macrophage production. These macrophages then invade the adipose tissue, and it will stimulate adipogenesis and adipocyte hypertrophy, which will then cause obesity. And this study tried to compare the energy expenditure between the non-PCOS and PCOS women. And they use PPT, which is postprandial thermogenesis, as a measure for energy expenditure. And what they found is that PCOS women have reduced energy expenditure. And they concluded that it is because of the inherent abnormality in the PCOS, that is adipocyte dysfunction, excess androgen, aberrant insulin signaling, as well as altered sympathetic activity. All of them contribute to the lower energy expenditure. And these extra calories are then deposited into the visceral adipose tissue, which is causing obesity. Now, many studies have shown that inflammatory markers are raised in PCOS women, and it is irrespective of their weight. So even in obese as well as lean women can have increased inflammatory markers. And all the different pathophysiological mechanisms of PCOS can contribute or can stimulate the inflammatory response. So in this diagram, as we can see that as we saw under obesity, similarly here, on consumption of the carbohydrate, there will be oxidative stress, which will activate toll-like receptors on mononuclear cells, which will then eventually lead to activation of nuclear factor kappa B, which will cause release of cytokines. And this cytokines will then lead to stimulation of C-reactive protein from liver, causing inflammation. At the same time, obesity, insulin resistance, hyperandrogenism, all of them contribute to the inflammation. And this inflammatory mediators will then invade the ovaries. It will stimulate the theca cell proliferation, and at the same time, it will stimulate steroidogenic enzyme within the ovary, that is CYP17, and increase androgen production. It has been found that in PCOS women, there is increased activation of Nlrp3. Now, for those who don't know about Nlrp3, I will tell you in brief about this. The full form of Nlrp3 is Nod-like receptor protein. There are about 14 NLRPs which have been discovered till now. The most studied one is Nlrp3. Now, what are Nlrp3 inflammosomes? Now, Nlrp3 inflammosomes are actually pattern recognition molecules which are present in the cytosol of a cell. There is another pattern recognition molecule which is present on the cell membrane, which is shortly called as TLR, or toll-like receptor protein. Now, what is their function? Their function is to detect a particular pattern. So it can be a DAMPs, like damage associated molecular patterns, or it can be PMP, that is pathogen associated molecular patterns. So there is like any kind of these patterns are recognized. This inflammasome complex gets activated. This will then activate many other signaling molecules. One of them is caspase 1. And this caspase 1 will then cleave pro-cytokines into cytokines, and then it will be released into the circulation. So NLRP3 is essentially the link between a particular signal and the inflammatory response. And it is found to be also elevated in many other disorders, including metabolic disorder. And it is a new therapeutic target for all these disorders. There is increased reactivity of HPA axis that is observed in PCOS women, and which predisposes them to the increased risk of developing various disorders, including depression. Even insulin resistance, obesity, and inflammation observed in PCOS can also contribute to HPA axis dysregulation. There is another inherent abnormality found in PCOS, that is cortisol, altered cortisol metabolism. So you can see there are two enzymes, 5-alpha reductase and 11-beta HSD1. And there is altered activity of these two enzymes, which is responsible for altered cortisol metabolism. I can explain you details about this from this diagram. So on left side of your screen, you can see 5-alpha reductase enzyme. What does it do? It metabolizes cortisol. Now you can see the thick black arrow. That means there is increase in the 5-alpha reductase activity. So it will cause increased metabolization of the cortisol. And because of which there will be increased ACTH secretion from pituitary in order to maintain normal level of cortisol. And this ACTH will secrete androgen production from adrenals, and which will then lead to hyperandrogenism. Another enzyme is in the middle of the screen. This diagram that you can see is 11-beta HSD1 and 11-beta HSD2. Our focus is 11-beta HSD1. Now, what does it do? You can see the direction of arrow. So what it does, it converts inactive cortisone into active cortisol. In liver, you can see this thin black arrow. That means the activity of 11-beta HSD1 is reduced. So again, there is less availability of cortisol in the circulation. And because of which ACTH secretion from pituitary is stimulated, and this excessive ACTH will increase androgen production from the adrenals, leading to hyperandrogenism. Opposite effect occurs in adipocytes. So there's thick black arrow. In adipocyte, 11-beta HSD1 activity is increased. And this leads to increased production of cortisol in the adipocytes. And this cortisol then stimulates adipogenesis and can lead to obesity. So you can see that there is tissue-specific alteration in the 11-beta HSD1 activity. And it has been implicated in obesity, metabolic disorder, as well as in PCOS. PCOS is a transgenerational disorder. The genetic and epigenetic mechanisms are being transmitted by the mother to the female offspring. And it has about 50% heritability. But apart from genetic and epigenetic mechanism, it is also the intrauterine environment of the fetus that also plays a role. It has been found that mother with PCOS will have high androgen levels even during pregnancy. And this high androgen levels will affect developing female fetus in different ways, as you can see on the screen, eventually predisposing this female child to PCOS in adolescence. Like many other non-communicable and metabolic disorder, PCOS is also a complex polygenic disorder. There are various genes which have been identified during genome-wide association studies. I've listed just 4 of them, but there are many more genes, and there are also epigenetic variants which are associated with PCOS. So this diagram is essentially a summary of all the pathophysiological mechanism of PCOS that we discussed so far, except genetics and prenatal mechanisms. And it shows the interaction between these different pathophysiological mechanisms, which eventually leads to the development of PCOS. So now we switch gears. We go to the next agenda on today. And the main agenda is the pathophysiology of depression in PCOS. And as I said in the beginning of my talk, Depression is the most common psychiatric disorder associated with PCOS, and there is 8-fold increase in the prevalence of depression in PCOS compared to non-PCOS population. And there are biological mechanisms which are at play here, which increases the prevalence of depression in PCOS. So I'm going to discuss these 4 pathophysiological mechanisms. And as you can see, all these 4 mechanisms have been discussed under the pathophysiology of PCOS, and they are closely associated with the development of PCOS. And all these mechanisms are also associated with development of depression. I will discuss one by one in detail. We all know, and there is ample amount of literature that is available on the bidirectional association between insulin resistance and depression. In fact, in our clinical practice, we have observed that if you have a patient of depression and diabetes mellitus, if good glycemic control helps in the good depression control, and good control of depressive symptoms helps in the good glycemic control. And many studies have shown that increase in HOMA-IR, which is the measure of insulin resistance, it increases the risk of developing depression. Now, this is a very interesting study, NESTA study, which is Netherlands study of depression and anxiety. It is a prospective study with a follow-up period of 9 years, done in the age group of 18 to 65 years of age. The study tried to look for etiology, course, and the outcome of depression and anxiety. And here they studied 3 surrogate markers of insulin. Of course, they studied many other things, but out of which is relevant for today's talk, is this 3 insulin resistant surrogate markers and its associated risk of depression. And you can see very interesting findings on the screen. That just 1 unit change in triglyceride to HDL ratio will increase the incidence of depression by 89%. A 5 centimeter increase in waist circumference increases the risk of depression by 11%. And 1 unit increase in fasting glucose level will increase the risk of depression by 37%. And this study concluded that insulin resistance does play a very important role in the pathophysiology of depression. Now, to understand how insulin resistance and depression are associated, we need to understand what is the insulin action in the brain. So next few slides is going to be focused on understanding the insulin action in the brain, which is essentially relevant with regards to depression. So major source of insulin in brain is from the periphery through saturable transport process. There is some evidence to suggest that some amount of insulin is locally produced in brain. Insulin receptors are evidently and widely available in the brain. To understand insulin resistance, let us understand a little bit about the insulin receptor. This is a diagrammatic representation of the insulin receptor and its signaling pathway. So insulin receptor is made up of alpha and beta subunit. Alpha unit is the extracellular and beta is transmembrane and intracellular. So when insulin combines with the extracellular alpha unit, it leads to the conformational change, and which leads to phosphorylation of the tyrosine kinase which is attached to the beta unit inside the cell. Now it is not shown tyrosine kinase, but this P denotes the phosphorylation of the tyrosine kinase of insulin receptor. This tyrosine kinase then phosphorylates IRS, that is insulin receptor substrate proteins. And this IRS then activates PI3K, that is phosphatidyl inositol 3 kinase. Then PI3K will activate different signaling molecules based on the desired insulin action. In this diagram, they have shown that it activates other signaling molecules, which eventually leads to translocation of GLUT4, which is the glucose transporter 4 from cytosol to the cell membrane, which increases the glucose transport into the cell. Now, brain is not completely dependent on insulin for glucose uptake, unlike the adipose tissue and the skeletal muscles. Because major part of the brain, in fact, has the GLUT1 and GLUT3 glucose transporters. few areas in the brain have GLUT4 glucose transporters. And when we are talking about insulin resistance, it is essentially the disruption in the post-receptor signaling pathway. So possible mechanism of insulin resistance could be either downregulation or genetic polymorphism or deficiency in tyrosine of insulin receptor substrate protein, or PI3K. So if we go back to the insulin receptor diagram that we saw earlier, there can be any defect in the tyrosine of the insulin receptor, in IRS, or in PI3K. So you can see these are the post-receptor pathways, and there is any deficit here, it will lead to insulin resistance. So if the brain does not require insulin for glucose transport, then why the insulin is required in the brain, and why do we have so many insulin receptors in the brain? Well, you can see on the screen, insulin has lots of important action in the brain. It is very important hormone in the brain and regulates many different functions and activities in the brain, as you can see on the screen. Now, there are some of these insulin actions which I'm going to discuss in next few slides, which are relevant with regards to depression. And first is mitochondrial function. So insulin and growth factor and mitochondria, there is constant crosstalk between them. And this helps in the normal and healthy brain metabolism and brain functioning. In fact, insulin sensitivity is important for the normal functioning of mitochondria. And normal function of mitochondria is important to maintain insulin sensitivity. And insulin modifies mitochondrial functioning at almost all levels. So as you can see in this diagram, it affects the energy metabolism, ATP generation, iron homeostasis, mitochondria inducible apoptosis, or cell organelle communication with endoplasmic reticulum or with nucleus, or other mitochondrial dynamic functions. And in case of impaired crosstalk between mitochondria and insulin, it will cause what is called as metabolic triangle. And what are the three components of the triangle? Insulin resistance, mitochondrial dysfunction, and inflammation in brain, and which can eventually lead to neurodegeneration. Now, we all know that mitochondria is the powerhouse of the cell, and brain is an organ with the maximum energy requirement. Mitochondrial functioning is very, very important for the normal functioning of neurons as well as glial cells, which will help them to adapt to different stimuli and with proper functioning, which is essentially what we call as synaptic or neuroplasticity. And mitochondrial dysfunctioning will adversely affect brain functioning and will also hamper the brain's ability to adapt to stressful situation, and which can then manifest as the depression. Insulin has mitotic effect, and insulin-like growth factor does have a role in the growth and development of neurons and glial cells. Insulin acts directly through insulin receptor and activation of PI3K mTOR pathway. It has neurotrophic effect in the hippocampus. It also acts via NMDA receptor. And through NMDA receptor, also insulin is able to carry out a neurotrophic action. So if I can show you in this diagram, so you can see that this is the NMDA receptor and this is the insulin receptor. So insulin directly phosphorylates Nr2 unit of NMDA receptor. At the same time, insulin combines with the insulin receptor, activates PI3K, which activates AKT, which is protein kinase B, and then which activates Nr2 complex. And this direct activation of Nr2 by insulin plus indirect activation of Nr2 through insulin receptor, which increases the calcium inflow into the cell. And this activates this CREB, which is cyclic AMP response element binding protein. And this CREB then increases the production of various neurotrophic factors, and which eventually improves synaptic plasticity as well as has a neuroprotective action. And insulin is a potent neuroprotective agent. It acts against apoptosis, even oxidative stress, beta amyloid toxicity, and ischemia, and acts directly through insulin receptor by activating PI3K-AKT-mTOR pathway. As you can see that by different mechanism, the insulin is able to reduce oxidative stress and protect the neuronal cells from any further damage. Insulin also regulates beta amyloid fibrillation. So in patients who have type 2 diabetes mellitus, they are at high risk to develop Alzheimer's disease. And one of the mechanisms is that insulin resistance leads to increased beta amyloid generation, and which leads to cell death and apoptosis, and which can eventually lead to neurodegeneration. Insulin also increases BDNF and also mediates TRKB-BDNF response. It is tropomyosin kinase B BDNF response. Now in depression, it has been found that there is a down regulation of BDNF, and antidepressants. In fact, one of the mechanisms by this antidepressant bring about improvement in depression is by upregulating BDNF and acting through TRKB-BDNF pathway. In fact, there are many different neurotrophic factors which are released in the blood, in the brain, not only BDNF, but most advertised, I think most discussed one is BDNF, and that is why we are talking about BDNF only over here. Insulin also has neuromodulatory effect. So it affects electrophysiological transmission and neurotransmitter concentration. It modulates GABA, norepinephrine, serotonin, and dopamine neurotransmitter concentration and the receptor availability. If you're talking about only serotonin and dopamine here, then it affects synthesis and metabolism of this hormone, this particular neurotransmitters at all levels. So it increases the uptake of tryptophan and tyrosine, which are the precursor molecule for the synthesis of serotonin and dopamine respectively at the blood-brain barrier. It also increases this amino acid uptake by the neurons. It also upregulates the enzymes which are responsible for synthesis of serotonin as well as dopamine. It reduces the activity of MAO-A and MAO-B, and this way it reduces degradation of this neurotransmitters after release into the synapse, and it prolongs their half-life. It increases insertion of dopamine transporter in the plasma membrane. With the effect, there is increased dopamine uptake from the synapse and reduced metabolism of dopamine. And it also activates striatal cholinergic interneurons and stimulates dopamine release. Cognition and memory. There is impairment in cognition and memory has been the core symptom of depression. And many of our depressed patients will come up with the symptoms. And there are two processes called as LTP, which is long-term potentiation and long-term depression. They are responsible for the consolidation of the memory. Now, what is long-term potentiation? It is the prolonged depolarization of the postsynaptic membrane. And what is long-term depression? It is the prolonged hyperpolarization of the postsynaptic membrane. Now, LTP and LTD, both the process is required for the memory consolidation. So LTP is always followed by LTD, which then prepares the postsynaptic membrane for next wave of LTP. So they continue in kind of a cycle. So LTP and LTD always occur one after the another. And this is how the memory consolidation occurs. Now, AMPA receptor and NMDA glutamate receptor and glutamate plays very important role in LTP and LTD. And insulin has a role in the induction of LTD. So I will explain you through this diagram. So follow the red arrows first. So this is where glutamate, it is released from the presynaptic membrane. It activates AMPA receptor on the postsynaptic membrane. And this will lead to depolarization of the membrane, which will lead to the removal of the voltage-dependent magnesium block from the NMDA receptor. And because of which, there will be high calcium flow into the postsynaptic cell, postsynaptic, and then it will, through various different signaling pathways, it will cause long-term potentiation of the postsynaptic membrane. And this will help in the memory formation. And then it should be followed by long-term depression. And that's where the insulin comes into the picture. So insulin attaches to the insulin receptor. It reduces the availability of AMPA receptors on the postsynaptic membrane. And this will reduce the depolarization of the postsynaptic membrane, and which will reduce the calcium flow into the cell. So it is by L calcium, that means low calcium into the cell, and which will cause hyperpolarization and long-term depression. There is another way also by which the insulin induces LTD, that is by recruiting GABA receptors onto the postsynaptic membrane. And this GABA, through a GABA A receptor, will cause synaptic inhibition, and it will also contribute to the LTD. And this LTP and LTD together will lead to memory consolidation. Now, in case of insulin resistance, there will be impairment of this LTD, and that will eventually cause memory difficulties and cognitive impairment. In experimental conditions like euglycemic hyperinsulinemic condition, the researchers have found that insulin administration improves the verbal memory and selective attention. Even some studies have shown that in patients with Alzheimer's disease and who have type 2 diabetes mellitus, insulin injection given for glycemic control also improves memory. And other actions of insulin like improvement synaptic plasticity as well as neurotrophic effects also helps to promote learning and memory. And this is the last action of insulin that we are going to discuss today, and that is insulin resistance in hypothalamus. We know hypothalamus is a very important area in the brain which maintains homeostasis in the body. Insulin receptors are present in hypothalamus. And in animal models, it has been found that insulin resistance in hypothalamus causes hyperphagia and mood symptoms. So how does it cause hyperphagia? So insulin is an anorexigenic. That means it suppresses appetite. At the same time, it also strengthens the activity of another anorexigenic hormone called as leptin. And insulin and leptin both act through the common pathway, that is PI3K pathway. And insulin and leptin together regulate the feeding behavior and appetite. But in case of insulin resistance and leptin resistance, it has been observed that there is hyperphagia and there is increase in appetite. Now, insulin resistance in hypothalamus will cause glucocorticoid resistance, which will eventually lead to impairment of negative feedback loop and lead to chronic activation of HPA axis. And we all know that chronic activation of HPA axis has close association with depression. And one more important action of insulin in the hypothalamus is regulation of the energy homeostasis. Energy homeostasis is not just by the peripheral insulin action on liver, muscles, and the adipose tissue. There is also the central insulin signaling in the hypothalamus, which also plays very, very important role in the energy homeostasis. And disruption in the central insulin signaling in hypothalamus is found to play an important role in the pathogenesis of metabolic disorder. And depression is one of the common comorbid condition in metabolic disorders. So having seen that how insulin resistance plays an important role in the pathophysiology of PCOS, and now having seen that how insulin resistance in the brain, which is called as central insulin resistance, will cause lot disruption in the brain functioning. And that is why today's star of the talk was insulin, because insulin resistance does play a very important role in the pathogenesis of PCOS as well as in the pathogenesis of depression in PCOS. We all know that there is a bidirectional association between obesity and depression. Many of our patients do have obesity, and those who have obesity, we have found that they are highly predisposed to develop depression. And it is abdominal obesity, which has a more strong association with depression than general adiposity, just like we had discussed in PCOS. And those people who have adverse metabolic profile with obesity are at heightened risk to develop depression. These are the 6 pathophysiological mechanisms by which obesity will lead to depression. So we'll discuss one by one. So first is genetic. Genome-wide association study has found around 200 loci which are associated with BMI. And most of these loci are present in the areas of the brain which regulate appetite, feeding behavior, energy, and mood. In fact, it has been found that most of these BMI associated loci are present in the brain and compared to the peripheral tissue, and which supports this thing that the energy homeostasis is more centrally regulated rather than the peripherally regulated. And there is a shared genetic architecture between obesity and depression. And this large collaborative study found that in those depressed patients who have either increase in weight or increase in appetite during the active episode, they will have higher number of genetic risk variants for BMI and CRP. We all know that chronic stress plays important role in the pathogenesis of obesity as well as in the depression. And this is like a shared neurological pathway between depression and obesity. And on right side of the screen, you can see that how the stress can contribute to the development of obesity and depression. So the chronic stress, which then causes activation of HPA axis, as well as activation of autonomic nervous system, essentially the sympathetic nervous system, causing systemic inflammation, which progresses to neuroinflammation, causing the disruption in the neurotransmission, neuroplasticity, neurogenesis, eventually causing obesity as well as contributing to development of depression. Now, there are several studies which have shown that everybody who is obese did not have insulin resistance. They're saying that it is the location of the adipose tissue which decides the odds of developing insulin resistance. So the deposition, lipid deposition under the skin, that is subcutaneous adipose tissue, will reduce the odds of developing insulin resistance. Whereas the adipose tissue around your visceral organs, that is visceral adipose tissue, will increase the odds of developing insulin resistance. Now, these studies have said that whenever there is a lipid accumulation, it first gets deposited into the subcutaneous adipose tissue. When the subcutaneous adipose tissue cannot expand any further, and there is an increased calorie intake, then these lipids then get deposited in the ectopic sites, and which are visceral adipose tissue, liver, and skeletal muscles. And ability of the subcutaneous adipose tissue to expand, it varies from person to person. And there are 4 potential mechanisms have been described, which could explain the insulin resistance and this relation between insulin resistance and obesity. I'm not going into detail about this, but if anybody is interested, can ask me during the question and answer session, I can explain them. Inflammation is hallmark of obesity, and obesity itself can trigger inflammation. So as you can see in this diagram, that in normal adipose tissue, whenever there is lipid accumulation, which causes the hypertrophy and hyperplasia of these adipocytes. Now, this hypertrophied adipocytes will compress on the surrounding blood vessels. This will cause hypoperfusion and hypoxia. This will lead to activation of macrophages, and this will lead to activation of transcription factor NF-kappa B. And this will then cause release of various cytokines as well as various adipokines. And this will then cause insulin resistance and hyperinsulinemia, leading to polycystic ovaries as well as metabolic disorder. And this peripheral inflammation will then translate into the central inflammation by various mechanisms. And inflammation in various areas of the brain will then cause the disruption, especially in the hypothalamus, will cause disruption in feeding behavior, energy homeostasis, and which will further lead to weight gain and obesity. And central inflammation will also cause activation of HPA axis and will adversely affect synaptic plasticity and neurotransmission, as well as synthesis of neurotrophic factors, which can then lead to disruption in the brain functioning, manifesting as depression. We know that gut-brain axis has been proposed as one of the pathophysiological mechanisms in depression. And obesity does have effect on the gut-brain axis. It leads to change in the gut microbiota, and it leads to what is called as leaky gut. That means it increases the permeability of the gut. So you can see on the right-hand side in the picture that there is increase in the permeability of the gut, which will lead to the leaking of toxic substances like the lipopolysaccharides. And this lipopolysaccharides then will activate the inflammatory cascade, and this peripheral inflammation will then cause the central inflammation. Now, neuroimaging studies have found that it is insula and hypothalamus are two areas of the brain whose functioning is altered in case of obesity and depression both. Now, insula is an area which is associated with the function of interoception. Means it gathers the information about the internal environment of the body, including the metabolic signals, the emotional states, and everything. It integrates this and then transmits it to different parts of the brain. And hypothalamus is the main area of homeostasis. It maintains the homeostasis of entire body. And insula and hypothalamus, they are extensively connected with the different areas of the brain. So any altered activity in insula or hypothalamus will also cause alteration in various networks through which they are connected to the different parts of the brain, which can eventually alter the brain functioning and can present as depression. Now we come to the third mechanism of depression in PCOS, and that is inflammation. Now, we know that there is an inflammation or inflammation-based theory in the depression, and in certain set of patients with depression, there can be high level of inflammatory markers. In fact, treatment with cytokines like interferon alpha or in patients suffering from inflammatory disorders like rheumatoid arthritis or autoimmune disorder or multiple sclerosis, they have high risk of developing depression. And researchers tried to see if there are any peripheral markers of inflammation which could explain this picture. And they found that there is an involvement of Nlrp3 inflammasome complex in PCOS. In fact, in the peripheral blood mononuclear cells, they found that there is increase in caspase 1 and Nlrp3, which supports that there is increased inflammation and which can then play important role in the pathogenesis of MDD. And we know that our antidepressants have anti-inflammatory property and they can reduce inflammation. And this study has shown that fluoxetine and amitriptyline do this by reducing Nlrp3 and caspase 1, as well as the levels of inflammatory cytokines. And this central inflammation brings about the neurotoxic effect in the brain. And one of the pathway that it does is by Inuranine Pathway. Now, I'll not go in detail about this, but what happens is that inflammation stimulates this Inuranine pathway, which eventually leads to production of quinolinic acid. And this quinolinic acid is neurotoxic, and it leads to various neurotoxic effects in the brain, which eventually can manifest as depression and can progress as neurodegeneration. We all know about the association between HPA axis dysregulation and depression, and I'm not going into details about it. And we saw in PCOS that women with PCOS are at heightened risk of HPA axis reactivity. And at the same time, altered cortisol metabolism in PCOS also predisposes them to alter HPA axis activity. So till now, we discussed briefly about the PCOS. Then we discussed in detail about the pathophysiological mechanisms of PCOS, as well as pathophysiological mechanisms of depression in PCOS. And now we come to the last part of today's talk, and that is the treatment of depression in PCOS. And first is pharmacological treatment. There is no difference in the treatment of depression in PCOS from the non-PCOS patients. Antidepressants remain the first line of treatment in depression. But albeit there is also one additional thing here is anti-diabetics. Now, there are studies who have shown that they may have a role in the treatment of depression. Metformin and pioglitazone are most studied antidiabetics in depression in PCOS. In fact, metformin is one of the first line medicine in the treatment of PCOS. And many researchers try to see whether it will be effective in the treatment of depression as well. But as of now, we do not have any conclusive evidence to support the use of metformin or pioglitazone in our regular day-to-day practice. We require more robust data, more robust studies, which will help us to understand the role of this anti-diabetics in the treatment of depression in PCOS. The non-pharmacological treatment of depression is the same as we usually prescribe in our routine practice. So there is no difference there. So this diagram shows different interventions, that is pharmacological intervention, psychological intervention, and behavioral intervention, and how it affects in the it has a role in the treatment of depression, as well as role in the different pathophysiological mechanisms of PCOS. So how we can combine these different treatment modalities to bring about the improvement in various different pathophysiological mechanisms based on the symptom profile of our patient. So to summarize, PCOS is a lifelong heterogeneous endocrine disorder having multisystemic manifestations. There are shared biological mechanisms between PCOS and depression, which we discussed in detail. And depression is the most common psychiatric comorbid condition, and all cases of PCOS should be proactively screened for depression. Antidepressants remain the primary pharmacological treatment for depression. So let's discuss. So I will end my, if there are any questions, I can.
Yes. Thank you, Dr. Amita, for your lucid lecture and presentation. There were many minute, important details which enlighten us on every aspect that how pathophysiology of this PCOS is connected with depression, particularly insulin resistant, and it may just helpful in understanding the picture of how patient of diabetes may suffer from depression. So that was very minute detail. I congratulate for the same. Now I will invite people to ask questions in chat box. Let me ask one question until some question received.
Yeah.
So basically it is just not related to neurophysiology or pathology for a while, but many of the patients who have already PCOS or PCOD, and sometimes gynecologists give OC pills maybe, depending on the indication. So again, progesterone may increase the depression sometime because OC pills has its own side effects related to depression. So in that case, according to your clinical experience, any specific antidepressant may be effective more or something like that, or any other approach, how to deal with such scenario?
Well, there is no specific any antidepressant to treat these patients if they are on OC pills. As you rightly said that OC pills can increase the incidence of depression in these patients. But then the treatment of depression in this patient will depend on the symptom profile and the patient profile. And the antidepressant has to be, so there is no difference as such in the treatment of the non-PCOS depressed patients versus PCOS depressed patients. In fact, if you see in the 3 case vignettes, 2 of the 3 were on OC pills. And
yes,
Then adding the antidepressant helped in the improvement of depression, and they are still continuing OC pills and they are still maintained on antidepressants, and the depression is under control. At the same time, the menstrual cycles are also regular.
Yes, we have received the one question. Why incidence of PCOD is increasing? Is it really increasing or diagnosis is increasing?
Well, it's an interesting question. It could be both. Okay, so one thing, it could be that diagnosis is increasing. Maybe there is more awareness. There is more openness. Now patients are open whenever they have irregular menstrual cycles or any other reproductive system related symptoms, they immediately go and contact their doctor. And as I said during my talk, it is the gynecologist who become the first point of contact. Now there can be increase. So when I say that in obesity, the obesity itself can cause PCOS by causing LH suppression, at the same time causing insulin resistance and inflammation. Now we see that there is rise in obesity in our children, and these obese girls are at heightened risk to develop PCOS in their adolescent or early adulthood. And these girls may not have any predisposing or any genetic vulnerability. So they may not have any family history of PCOS, but simply because of obesity and obesity related all other mechanisms can make them vulnerable to develop PCOS.
Next question is just very broad general advice for prevention of psychiatric comorbidity, maybe in patient with PCOS.
Same as in our regular practice. 3 mantras for them: eat well, sleep well, and exercise well. And stay away from all the substance of abuse that will keep them well. Because there is no other specific advice for this women. Apart from that, depression here is part of a big syndrome called as PCOS. So the idea to understand this pathophysiology is because when these patients come to us, we know that depression is not just alone. Here they have a bigger syndrome, and addressing different components of the syndrome will help in the proper management of these patients. So if you know someone who has PCOS, and if you want to advise some preventive measures, you can educate them about the metabolic problems. If they are obese, they can be advised to lose weight with proper dietary changes as well as regular exercise. And these patients can undergo regular metabolic profile evaluations and even psychiatric evaluation. And they can be advised to have more healthy lifestyle, which will help them to, avoid, but at least maybe prevent development of this particular psychiatric comorbidity.
Next is, what is epidemiological data of resistant depression comorbidity with PCOD?
I'm sorry, I don't have that idea. I don't think so. Any study has specifically tried to look for resistant depression in PCOS. I have not come across any study when I was preparing for this talk. I don't think so. There is any such data exist. And if it exists, do let me know. It will help me.
Then there is a case-like thing. I know of a 19-year female with obesity and history of PCOS in elder sister and DM in mother. Recently, she diagnosed as an inflammatory bowel disease. Can you tie this loose ends? She has mood swings. So is it feasible to add antidepressant mood stabilizer to existing medication?
Okay, so now this is a 19-year-old girl with obesity. So she is already predisposed. She already has one component of metabolic disorder, also has a genetic vulnerability to develop PCOS, and elder sister is diabetic. So there is a genetic loading for metabolic disorder in this patient. This patient herself has obesity and may be predisposed to PCOS, may develop or may not develop, and inflammatory bowel disease. So these are all interlinked. It is not separate. And mood swings, it is feasible to add. Now, mood swings, one needs to evaluate further. Mood swings just doesn't make any sense. What is it? Are they part of personality, or is it depression? Or are you talking about mood swings in the sense of bipolar mood disorder? What is it happening? And mood swings, and then the treatment has to be advised accordingly. Anything else that Dr. Chintan you would like to add here?
Nothing specific. You are absolutely right. We need to evaluate, and we have to sometimes give choice to the patient that they want some preventing kind of treatment in terms of depression, or they just want to wait. Anyone else in audience would like to ask any question? So I think we can conclude here. Thank you, madam, once again for a very great experience of this routine topic, but not heard any lecture on this topic. That was very interesting.
It is less discussed amongst us psychiatrists, I think.
Yes, definitely. But it is very important.
Yes.
So over to Dr. Rasmin.
I would like to just say one thing before I end, that the references for today's talk, about 50 references, will be available once this presentation is uploaded on the website. One can use them for further reading.
Thank you.
Great.
Yeah.
Thank you. Brilliant. Thank you very much, Amita. That was very lucid and very extensive as well. So it did test our limits of attention span to an extent.
I'm sorry to exceed
the
time limit.
No. There's no time limit to this. So, but it was an extensive topic. So you had to do justice to it, and I'm happy to you for that. And thank you very much for a very detailed and a very lucid talk, which brought about a lot of areas to the fore, and I think that was perhaps what we needed. So thank you very much once again, Amita, and thank you, Chintan, for having hosted this and chaired this session in a very eloquent manner. Thank you to Rahul, Shama, and Madhav for the questions they posted, and to all the other attendees who came along and attend this talk. We're very grateful for you to have taken the time, and hope you enjoyed it as much as we enjoyed bringing it to you. And we promise to continue to bring you interesting topics every time. And of course, thank you to Sun Pharma for their unflinching support. Until the next month, when we come up with another interesting topic for you, we wish you all a good evening ahead, and have fun in the festive season that we are in the middle of right now. Thank you all once again. Thank you.
Thank you.
Thank you. Thank you.